So I just start sharing my screen.
Good evening.
Good evening. So I think all of you can see my screen now. I'll just make it full screen. So welcome to the 74th Painel Journal Club. This season we are focusing on MSK Ultrasound, and today we have the topic which is on sports, related to sports and sports injuries as well. So I welcome all the faculties and speakers. I'll just introduce them in a moment. Before we go ahead, I just introduce the journal club to those of you attending for the first time. So pain medicine world over has got diverse issues and variable standards, different learning requirements and different offerings. Both money and time, they prevent most of the physicians from accessing quality education. To overcome these barriers, Mumbai Pain School was formed as an initiative of Panisha Spine Wellness and Pain Relief Center, and we focused mainly on online education to start with, and used Facebook, Instagram, Twitter, and other social media channels. And most of our content is based on online learning and on-demand videos. We have most of content which is free, but we have some paid content as well. We started with the hands-on workshops as well a few years back, and we were fortunate to have expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. A journal club is nothing, just a club. The only difference is that here we critically evaluate recent academic literature, which is based on a defined subject, and attendee participation is most important. So we encourage all the attendees online as well as on Zoom to just ask questions, give comments, suggestions, whatever they want. It is very tough to be regular. As I mentioned, I see new faces each time. So try to be regular. The journal clubs are very important. Even Harrison conducted his own journal club twice a month. The purpose was the same: critical evaluation of academic literature. So time and discipline is important. So please, speakers, kindly stick to your timelines. Healthy skepticism or praise is most appreciated. So that should be welcomed. A bit about me. I am from Mumbai, and I practice pain medicine since last 10 years now. So, but today we have with us our esteemed faculties. Dr. Karthic Babu Natarajan, who is an MD/DNB, FIPM, FIPM, FIPP, is a consultant pain physician and associate, also director, Synapse Pain and Spine Clinic in Chennai. He is also the consultant spine and pain physician at Apollo Hospital, Chennai. He is the chairman of WIP India section, that's World Institute of Pain. Also the secretary of the ISSP Tamil Nadu state, and he's been awarded. He's got, I think, multiple things. He's just mentioned one of them. So, Pain Physician of the Year 2017. Welcome, Dr. Karthik.
Thank you.
Thank you. So we also have with us Dr. Sanjog Mekewar. He's done his DNB and FIPM. He's a consultant in interventional spine and pain physician. He's at multiple hospitals in Pune. He's also the visiting consultant at BJ Medical College and Sassoon Hospital in Pune, and the director of Jeevisha Pain Management Center at Pune. His area of interest include the regenerative medicine, spine endoscopy, and he's got multiple publications in the national journals, and is an avid traveler and explorer. So now, kindly allow me to introduce the speakers for today. I think Dr. Sneha, you're ready with your slide. You're going first, suppose.
Yes, sir.
So I think you can start sharing your screen. I've already made you the co-host, and we can I can just put up your CV slide. So I will just introduce you. Yeah, we can see your screen. Thank you. Yes. So Dr. Sneha Shreyas is she's done her DNB FIPM, and she's a medical director and consultant pain physician at the PainX Advanced Pain Management Center at Bangalore. and she's also the consultant anesthesiologist at MENTS Men's Hospital at Bangalore. It's a famous ENT hospital. So over to you, Dr. Sneha.
Thank you, sir. It's not moving.
So just click once on the screen and it will start to move.
Okay. Yeah. Today we are discussing on, as sir said, today it is about sports medicine ultrasound. The topic of the journal today, which we'll be discussing, is implementing ultrasound imaging for assessment of muscle and tendon properties in elite sports, practical aspects, methodological considerations, and future directions. This was published in Sports Medicine Journal in 2021. The co-first authors are shared by Fabio Sato and Georg Sporio from Department of Biomedical Sciences, Italy, and Sports Medicine Research Group from Department of Orthopedic from Switzerland. Coming to introduction, ultrasound imaging represents a relatively affordable, non-invasive in vivo method for examining the morphological and mechanical properties of muscle and tendon. Commonly, B mode, that is the brightness mode, which is become widely adopted to quantify skeletal muscle mass and architecture. Now, the recent advances in ultrasound like EFOV, that is extended field of vision technique, 3D ultrasound, shear wave elastography, and imaging. In elite sports setting, the assessment of muscle and tendon anatomical and mechanical properties has a great potential for testing athlete status with respect to performance-related factors and their response to training, to detect athletes at high risk of injury, to screen athletes for structural abnormalities related to current or future musculoskeletal complaints, and to monitor the return to sport after a musculoskeletal injury. The aims and objective of this journal was to mainly summarize common principal ultrasound measures and field of applications in the context of elite sports, to highlight methodological perspective, the strengths and limitations of ultrasound imaging for assessment of muscle and tendon properties, and to provide future directions of research and application. Coming to practical aspects, first coming to principal ultrasound-based measure, first the authors have described the main muscle architecture. Basically, the definition goes like this: macroscopic arrangement of muscle fibers within a muscle relative to the axis of force generation. To evaluate this, the transducer is aligned along the plane of the muscle fascicle to distinguish the orientation of fascicles relative to the transducers due to the presence of higher contrast between connective tissue and muscle tissue. The correct alignment is very essential for image quality, as while imaging in ultrasound, we take the advantage of anisotropic nature of the muscle. In this, the length of the muscle fascicle, that is LF, and the pennation angle, these are determined by either using B mode or EFOV, one of the primary determinants of muscle function. This can influence muscle force length and force velocity relationships. Coming to the next aspect, that is muscle dimension, it can be evaluated by either linear, two-dimensional, or volumetric indices. In this, muscle thickness represents the simplest and most employed measure of the dimension. B mode ultrasound, again, it is measured by using linear perpendicular distance between the skeletal muscle interfaces. Here also, the transducer can be placed either longitudinally or transversely in relation to the region of interest chosen for the specific muscle. In this diagram, they have shown three muscle groups. In this, the longitudinal B mode of ultrasound representing the three muscle groups. That is how to measure the fascicle dimension. To assess larger anatomical structures, that is muscle anatomical cross-sectional area, which is acquired in the transverse plane. Anatomical cross-sectional area can either be done using image stitching technique or extended field of vision imaging. Extended field of vision imaging is valid and reliable method for assessment of quadriceps, gastrocnemius, and hamstrings, according to the authors discussed here. And this plays a vital role in athletic performance or clinical settings. In this transverse extended field of vision scans, they have done in three muscles: quadriceps, hamstring, and triceps muscle group. Coming to the third aspect, that is muscle quality. This is obtained by quantitative musculoskeletal ultrasound. Echo intensity is the measure of reflectivity of sound waves reflected by the tissue. That is considered as proxy of muscle composition, and it may be used as index of muscle quality. Connective tissue and fat are more reflective than the muscle, so they appear in the image as lighter gray. And this largest ROI is detected, and echo intensity is measured as calculated by median grayscale values, that is 0 to 255, and low echo intensity values mean greater muscle quality, and higher value means indicates muscle impairment. And ultrasound is a reliable tool for assessment of muscle quality. It is mainly used to study muscle quality changes with respect to aging. Coming to the next, that is tendon dimension, most commonly represented by tendon thickness and again anatomical cross-sectional area. Tendon thickness is obtained by longitudinal scan via B mode in resting state. This tendon ACSA can be measured from axial plane ultrasound images taken at different portions of tendon length. It is related to the distribution of stress within the tendon itself. Coming to the last property, that is tendon mechanical properties, capacity and effectiveness of these tissues to transmit muscle force to the bone and thus enabling movement. This can be determined in vivo, estimated by force elongation relationship, and tendon stiffness is calculated as force divided by tendon elongation. Combination of B mode ultrasound with isometric dynamometry enables the measurement of tendon deformation and force produced during isometric contraction. In this, we can see in the image A and B, we can see patellar tendon at rest and during isometric contraction. The dotted line represents the elongated part of the tendon. The C and D images represent Achilles tendon. C is at rest and D is again during isometric contraction. The dotted line represents again the elongation of the muscle fiber. Muscle and tendon stiffness measured with elastography. The recent introduction of shear wave elastography ultrasound for assessment of muscle and tendon mechanical properties. Estimation of stiffness is done in the form of an elastogram. And the most commonly used SWE technique is supersonic shear imaging, and this is operator dependent technique. In the image, we can see in A the normal shear wave elastogram, and the B represents stiffness when it is present in the muscle, and elastogram is evaluated. Muscle and tendon stiffness measured with elastography. It is a reliable tool to evaluate the mechanical properties of different muscles at rest and during passive stretching. Muscle and tendon stiffness are likely to influence the joint mobility. This is used to assess stiffness changes which is related to training, stretching, manual therapy, or maybe because of our procedures and after injuries. Coming to the fields of application in elite sports, mainly testing the athlete status with respect to performance related factors and their response to training. This is by knowing the muscle or tendon morphological and mechanical properties which are influenced by training. Skeletal muscle hypertrophy, it occurs in response to strength and plyometric training. Different adaptations has been noticed in the architecture with different combined modalities of training that can be structural, anatomical cross-sectional area, or mechanical or tendon properties, which are increased after loading interventions. The next one is detecting the athletes at high risk of injury. The injury occurrence is regulated by complex mechanical interplay between tissue stress, strain, and loading alterations in muscle tendon properties. Periodic screening via ultrasound may help in estimating a potential risk factors for injury. Measurement of these dimensions appear to be related to musculoskeletal injury. The next important is to screen the athletes from structural abnormalities related to current or future musculoskeletal complaints. Ultrasound and shear wave elastography are the main diagnostic tools for evaluation of tendinopathy, tendon injuries, and rupture. Increased anatomical cross-sectional area are observed in these injured tendons due to collection of fluid, that again due to hypervascularization. Muscle stiffness related to muscle activity and joint mobility can also be linked to tendinopathies. And the next important one is monitoring the return to sport activity after musculoskeletal injury. This evaluation is helpful and to examine the effectiveness of rehabilitation programs. Muscle architecture is known to be affected by musculoskeletal injury. So ultrasound is used to characterize the behavior of fascicles during the return of sport using the pre-injury measures or contralateral uninjured limb as the reference. Coming to methodological considerations, mainly muscle ultrasound and tendon ultrasound. Under muscle ultrasound, the two important things discussed are muscle architecture and muscle thickness assessment. And under the tendon ultrasound, assessment of tendon mechanical properties. This is most challenging to implement in sports scenario due to many methodological and technical aspects. The use of both tendon insertion points as opposed to the structural related structures such as aponeurosis is recommended. Coming to general issues, first is echo intensity assessment. This rely on grayscale analysis. Ultrasound settings must be kept consistent between pre and post measurements, and the measures do not show great sensitivity for changes in muscle quality after training. This shows the difference in the anatomical cross-sectional area between the previously injured muscle and healthy muscle tissue in the quadriceps where the authors have discussed. Coming to the next important thing, that is shear wave elastography. These systems are built on assumption that analyzed soft tissues are completely elastic, incompressible, and isometric tendons and muscle exhibit an anisotropic behavior. Shear waves travel at higher velocity along the direction of fibers compared to transversely to them. It is essential to standardize the transducer position, and we should align the transducer to the muscle or tendon fibers. The factors which influence the outcome are transducer pressure, region of interest, size, and the scan acquisition time. This should be performed by using lightest transducer pressure, shortest acquisition time, and maintaining a constant ROI size. The propagation of shear waves is attenuated at greater acquisition, so this is dependent on the surrounding tissues. The next important is B mode versus extended field of vision. Main limitation of B mode ultrasound is it has a small field of vision because the transducer size is limited. The length of the commercially available probe is usually 4 to 5 centimeter. This limited field of vision will affect when larger muscle of interest is there, when the fascicle length of the muscle is complex. And coming to extended field of vision technique, this allows study of larger anatomical structure, so overcomes the limitation. This can overcome as the restricted field of vision of the transducer. This is used to evaluate anatomical cross-sectional area by performing transverse scan, and by muscle architecture by performing a longitudinal scan. This is important in muscle with longer fascicles and to evaluate architectural changes between different portion of muscles. And all the ultrasound devices do not enable the possibility to perform this scan. Coming to static versus dynamic ultrasound, B mode seems to be a reliable method to evaluate muscle architecture during movement. Sports activities characterized by combination of movements, musculoskeletal injuries, which generally occur during dynamic contraction. So these are obtained by dynamic ultrasound, which are more informative when employed in a sports context. Technical considerations that limit the use of dynamic ultrasound in an applied sports setting should be considered. Operator and raters experience. This is an operator dependent procedure. Extended field of vision scans are more difficult to acquire compared to B mode ultrasound, as it is a challenge to place the transducer parallel to the fascicle plane. So extensive operator training is definitely important. Coming to future directions, training is required for acquisition of skills, and new specialized figure should be introduced in teams or federations interested in implementing this technique. Further research on designing new tools for data processing and analysis, and aim to give real-time feedback to the staff with more objective. These are the future directions according to the authors. Coming to conclusion, Ultrasound has a promising application areas in elite sports scenario. Practical and methodological considerations elaborated here should be considered to provide information for benefit of athletes' performance enhancement and for health protection. And agenda for potential future research in implementing the ultrasound imaging in elite sports. Quickly, I want to just summarize their do's and don'ts. We need to use an ultrasound that fits our necessities, not the other person who is using, because we will be the best person to judge what I need the most. And operative timing is definitely required, as it is always said. Eyes can't see what the brain doesn't know. So if our anatomy knowledge is sound, then only we can see what, the muscle or any structure which we are scanning. And alignment of the transducer to the muscle plane, and it comes with the time. As we keep on scanning and doing procedure, we will learn it better. And the steps which the authors have advocated, like to avoid it, is absolutely apply no pressure and try to avoid single scan site. And it should not be like extended field of vision is not the solution to everything. We need to implement this technique only when it is necessary. Coming to the limitation, according to the authors, all mid-segment ultrasound machine will not be equipped with these advanced features like extended field of measure. Operator training plays a vital role. So operator bias also plays an important role in the techniques they have implemented. Coming to critical analysis, I found that MRI has not been taken into consideration in this journal or to compare the data, so that we will not know the exact sensitivity of ultrasound to measure the let it be the muscle dimension, thickness, or tendon fascicle length. So no inclusion or exclusion criteria has been defined, and the clinical scenario is never highlighted in this specific journal. Coming to take-home message, ultrasound is definitely the best modality to evaluate sports injuries, and major advantage being it's non-invasive, and we need to expertise and make the best use of ultrasound. However, clinical diagnosis always comes first. Thank you.
Thank you, Dr. Sneha. Now, I request Dr. Akhil to start with the second presentation. We'll take the Q&A in the end together. Dr. Akhil Bhalla has done his MD, FIPM, FIAPM. He is currently the assistant professor and in charge of pain medicine at Department of Anesthesia and Pain Medicine at Adesh Medical College, Ambala. He is a founder and consultant of PainX Advanced Pain Management at Chandigarh, and is also the visiting interventional pain consultant at hospital in Chandigarh. Over to you, Dr. Akhil.
Thank you for the introduction, sir. Very good evening to everybody. So the topic for discussion, or the second topic for the Journal Club, this article is titled as Sports Ultrasound, Advantages, Indications and Limitations in Upper and Lower Limb Musculoskeletal Disorders. So this is a review article, and this was published in International Journal of Surgery 2018, and this was published by Naveen Balocha et al. This was conducted in the Department of Surgery, Pakistan, and in coordination with Yamada from the Department of Sports Medicine in Japan. So coming to the introduction, a bit about history of the ultrasound. Ultrasound was used in sonar to basically measure distance under the water using sound waves, which was back way in 1826. But the earliest report of use of ultrasound in musculoskeletal examination or musculoskeletal use was in 1972, when Baker's cyst was differentiated from thrombophlebitis. And then again in 1978, 6 years later, it was utilized to demonstrate the synovitis and evaluate the result of treatment in rheumatoid arthritis. So ultrasound, unlike CT scan or X-rays, does not expose the patient to radiation. It is safe even with pacemakers and metal implants and in those with claustrophobia. So the appeal of ultrasound, of course, is because of its very low cost, non-invasiveness, and easy availability, as it is a very portable device in clinics. So the American Medical Society for Sports Ultrasound recently proposed changing the name of the ultrasound used within medicine from musculoskeletal to sports ultrasound as a more accurate delineation of broad and unique application of ultrasound in this subspecialty. What the authors were talking about here was the subspecialty of surgery or orthopedics. So coming to indications and general considerations of USG. So ultrasound can lead to significant reduction How significant you are? Parker et al. Conducted a study, and they estimated that replacing MRI with ultrasound for the evaluation of just one specific shoulder pathology would save the United States at least $7 billion in healthcare costs between the years of 2006 to 2020. This would be the cost. So you could use ultrasound to delineate anatomy in relation to the textures of the tissue in consideration. It helps in earlier detection of pathologies than with CT, MRI, or X-ray. So what is ideal? It has a real-time ability to intervene and check the response in case of therapeutic procedures when doing intervention, such as aspiration of a joint or a cyst and guiding biopsy of soft tissues masses. Repeatability helps in monitoring the disease progression in case of partial tendon tears and even response to the treatment later. So coming to the advantages and limitations. The advantages would be it is non-invasive, there is no radiation exposure, it is very portable, available, it is relatively inexpensive as compared to CT or MRI. It is safe in patients with pacemakers and metal implants, effectively having no contraindications whatsoever. The patient does not have claustrophobia. Many patients do come with claustrophobia, the MRI and CT. Higher resolution images can be seen. No known contraindications, real-time assessment. It has a dynamic examination. Can interact with the patient while imaging. So it is very cooperative for the patient as well. Rapid contralateral examination for comparison, which is not available in other modalities. Repeatability to monitor the progression. And again, as you can see that it is inexpensive. And also to guide procedures for injections, aspirations, or biopsy. Coming to disadvantages, it has a very limited field view, and especially when it is deep. Incomplete evaluation of bones and joints, something under the bone cannot be seen, and limited penetration. A very deeper structure would not be able to see, especially when the patient is fat maybe. And operator dependent. Now, this is a very significant limitation of ultrasound, that is experience dependent. It has a good learning curve, and it has a lengthy training period. And there is dearth of certification development in musculoskeletal ultrasound. So what are the basic technical considerations for musculoskeletal ultrasound? You need to have a very comprehensive knowledge of the anatomy before doing the ultrasound. You need an accurate selection of the ultrasound machine, setting, and a sound review of the machine manual before doing it. The probe selection is very crucial for optimum visualization of what you want to see. So these are the three probes. This was a photo given by the authors. These are the three probes which are usually used. And this is the linear probe and the hockey stick probe. The hockey stick probe has a frequency of 15 to 7, that is a high frequency. Again, this is also a high frequency probe. The helpful point is the transducer is a linear array with a small footprint. The footprint in the linear array probe is a longer one. And again, this is high frequency, 17 to 5, as you can see. This is the curvilinear probe, usually used to see deeper structures. When you're doing a pelvis or maybe a spine ultrasound, then you will need this, which is a 5 to 2 megahertz. Okay, so now we'll be discussing some joints which the authors have discussed. So this was the shoulder joint. On an ultrasound, when you keep the probe in this position on the bicipital groove anteriorly in a cross-sectional view, this is what you will see. This is the lesser tuberosity, greater tuberosity. This is the biceps tendon. This is the transversehumeral ligament. This is the deltoid muscle over it. This is the deltoid fascia. This is the dermis and the subcutaneous area. This would be the subscapularis. In the similar position, if the probe is kept in a longitudinal way, this would be the deltoid. And underneath, you can see the long head of the biceps. And what you cannot see below this sharp line is the humerus. There would be a dot here, which would probably be the anterior circumflex humeral artery. So around 30 to 70% of the chronic shoulder pain would be because of rotator cuff pathology. Rotator cuff tears are the most common non-traumatic upper limb cause of disability in patients over 50 years. So overall accuracy of ultrasound in detecting these pathologies is 96%, which is quite high. This includes a sensitivity of 100% and a specificity of 85%. Why is this important? Because this correlates very significantly with the specificity and sensitivity of an MRI. A pathological subacromial bursa can be seen as a thickened bursa that is more than 2 mm on an ultrasound. You can measure it, and it could be hypoechoic. If there is a fluid collection there on the dependent side, which would be 3 to 4 centimeters distal to the rotator cuff attachment on the greater tuberosity, this is known as the teardrop sign, which we see. Now, the point to be noted is ultrasound cannot differentiate between septic and aseptic pathology of the bursa. And for that, you might need to aspirate under ultrasound, which is mandatory, and give the fluid for cytology. Coming to the elbow, if the probe is placed in the longitudinal position on the anterior aspect of the elbow towards the lateral aspect, what you can see here is the capitulum. This is capitulum of the humerus. This would be the radial head. This black dot line would be the articular cartilage. This would be the synovial fringe. This would be the brachialis, and this would be the brachioradialis muscle. This would be probably a vessel. And similarly, if you take the probe slightly inferiorly and medially, what you can see is the brachialis on top that would become larger. And here you would see the pronator teres. This would be the capitulum. So this would be the coronoid process, and this would be the coronoid process, and this would be the coronoid fossa. So the coronoid fossa has a fat pad over it. This would be the articular cartilage, and this would be the synovial fringe. So coming to elbow pathologies, the use of ultrasound is in the dynamic imaging, which you can see. You can assess the collateral ligaments very nicely, and you can assess subluxation of the ulnar nerve on a dynamic scan, or the triceps tendon even, and intra-articular bodies inside the joint space. So what is recommended by the authors is that instead of doing a pathological scan first, always go with a systematic approach for the complete evaluation of the elbow with its three joints, that is the radiocapitular, ulnotropical, and the proximal radioulnar, with the muscle attachments of all the muscles and the neurovascular structure. So in order to simplify this approach, you need to divide the elbow into anterior, lateral, medial, and posterior compartments and go one by one. And as a rule, always compare with the contralateral side. So coming to the ultrasound of the wrist, the only examination which the authors provided was when the probe is placed in the linear probe is placed in the cross-sectional view or the elbow at the wrist, sorry. And this is what you will see. This white line with the black hypoechoic area would be the flexor retinaculum. This honeycomb appearance, which you can see, is the median nerve. This would be the flexor digitorum superficialis and the profundus tendon. Here would be the ulnar artery along with the ulnar nerve. This would be the pisiform bone, and this would be the scaphoid. The capitate and hamate would make the base, and this is the carpal tunnel. This is where you can see impingement of the median nerve inside the carpal tunnel. So for wrist and hand ultrasound, you need a very high frequency probe. A hockey stick probe has a small footprint, and it is very useful in such cases, even for intervention. And it gives better images than a linear probe. So the conditions would be a joint swelling, inflammatory conditions, tenosynovitis, tendinitis. A trigger finger is very beautifully seen on a hockey stick, and ganglion osteoarthritis. And again, what you saw was the carpal tunnel. Ultrasound can guide therapeutic procedures. Aspiration and the joint tendons or joint injections can be done. Increased accuracy as compared to palpation guided procedure. So the next scan that the authors provided was the hip. So if the probe is placed longitudinally on the anterior aspect of the hip, this is the image that you'll get. This will be the femoral head. Here would be the acetabulum, and this would be the labrum. Covering it would be the hyaline cartilage, and the iliofemoral ligament would be here. This is the iliopsoas muscle, and over it would be the subcutaneous fat. If you would place the probe in a cross-sectional view on the same area, this is the first bony structure that you see. This would be the ASIS, or the anterior superior iliac spine. Arising from it or attaching here would be the inguinal ligament, and just below it, what you see right here is the just medial to the ASIS would be the lateral femoral cutaneous nerve. Now, this is a very notorious nerve. It would not exactly be there all time, but this is how you can see it. Underneath would lie the iliacus muscle. So for the hip, pathologies for the hip, I think the authors suggested that age plays a huge part in diagnosing the hip pathology. Children who are in the age of 2 to 12 have reported to have muscle tendon strains, ligament strains, and even contusions in 60% of the acute injury. In adults, on the other hand, athletes have a risk of developing osteoarthritis over the age of 40, with men being 4.5% more likely, and veteran athletes have a risk of 8.5% more than other people. Ballet dancers have more hip-related problems in the future. So to make a diagnosis in case of an iliopsoas bursitis, it could mimic an inguinal hernia. For such cases, a dynamic ultrasound and instruct the patient to move to allow proper assessment and diagnosis is required. The use of ultrasound would be to diagnose bone pathologies, occult fractures or bone erosions can be seen, synovitis, and early diagnosis of arthritis. So it is always recommended to compare the differences between the affected hip with the unaffected hip to estimate the level of pathology in such cases. So the next scan was of the knee, probe placed in the longitudinal position or right on top of the knee, just above the patella. So here the authors did not provide an ultrasound image; they just provided a image what you might see on an ultrasound. So this would be the patella, this would be the suprapatellar fat pad, and this would be the prefemoral fat pad. With this blue thing that you see here would be the suprapatellar recess, and this is the femur, this is the quadriceps tendon, and the subcutaneous tissue. And similarly, when you turn the probe around 90 degrees, that is cross-section view, you'll see the quadriceps tendon, that is this one, the number 3. Underneath it would be the suprapatellar fat pad. This would be the articular cartilage, and this is the condyle, and this would be the intercondylar circle. So for the knee pathologies, they are usually soft tissue pathologies, ligament tears, sprain, fluid collection, meniscal tears and cysts, contusions, fractures, dislocation of the patella can be seen. There is a limitation that you cannot visualize the menisci properly, but again, this has been countered because recent studies have shown that even menisci can be seen properly. Suspect presence of tear and presence of an irregular hypoechoic cleft within the substance of the menisci. Now, posteriorly, you can actually see the menisci. Accurately diagnose the point of tears or hematoma can be done with the ultrasound. What we try to see here is note the disruption in the tendon striation when you look for a tear. So deeper structures such as cruciate ligament pathology are best left for an MRI imaging. Again, cruciate ligaments are deeper structures and they might not be seen properly. Yet, ultrasound has been successful in assessing the cruciate ligament injury enough to diagnose the type and the degree of the injury. Such as the PCL, that is posterior cruciate ligament, it can be visualized from a posterior approach as enlargement of the normally hypoechoic ligament. Now, coming to ankle and foot, there was no images provided for this, but they did mention this. The sports injuries, ligament tears, tendinosis, tendinosynovitis, sprain, rupture, tarsal fractures of the foot. Ultrasound is very sensitive, highly spatial resolution for these superficial structures. If we do a dynamic scan, we can note the tendon impingement during this motion and can diagnose an osseous abnormality. You can see it on an ultrasound. Pathologies of the Achilles tendon are difficult to diagnose using MRI, which is very easy to diagnose using ultrasound. With slight physical manipulation of the injured area, you can even have sonopalpation to rule out that. For plantar fasciitis, ultrasound has reported 80% sensitivity, 88% specificity. Ultrasound has shown a high accuracy in detecting metatarsal bursitis and metatarsal fractures due to metatarsalgia. So coming to the critical analysis. So this was a review article which addresses very limited pathologies for the diagnostic value of the ultrasound to identify MSK conditions, and it was not an in-depth review. The intervention techniques were merely mentioned, not discussed, nor shown as a part of sports ultrasound, which makes up a major part of it. And this is not a systematic review, and hence did not mention the methodology or how even the review of literature was acquired for the article. So I think the take-home message would be that ultrasound used in sports medicine is very cost-effective in diagnostic musculoskeletal conditions, as well as to guide intervention procedures, whether therapeutic or diagnostic. I think the best point about ultrasound musculoskeletal is that it has no proven contraindication. It can be used in almost everywhere. The only limitation which would hinder you from using it would be the steep learning curve, which can be overcome with proper training and proper guidance with experience over years. Thank you.
Thank you, Dr. Akhil. Now I open the floor for questions. So anyone who has any questions, please type in the chat box. Those of us you are joining from the from Facebook or YouTube, please just type in the questions. We'll fetch from there. And over to you, Dr. Karthik and Dr. Sanjog, for any questions or any comments.
Thank you, Sidharth. So excellent presentation, Dr. Sneha and Dr. Akhil. Good job. So the articles that have been given are more like a tutorial on how we go about doing ultrasound-guided procedures for diagnosing and eventually treating patients with sports injuries. So in principle, the line in which it's going is perfectly fine. So when we do treat sportsmen and elite sportsmen, if you have an imaging modality in your clinic, it does make sense to do it in the outpatient ward itself. So that's good. Now, probably what I would add on is the technique is okay. You can add on like extra spectrum, and you can use your shear wave and other stuff, which would be add on. Sometimes we may not get these machines in India, so they're going to add on more information to already what you get. Now, probably in principle, both these articles are guiding us to how we should enhance our practice with ultrasound, especially in sports medicine. All that is acceptable. Now, probably my message for before is young and watching this is fine. But now, two things. When you're treating generally sportsmen, now you have to consider that sports injuries, you have to understand that unlike normal population, they have a very limited shelf life. So you cannot afford to make any injuries in sportsmen, especially people who are elite, who are playing for elite clubs or playing for the country. So they have a shelf life of about 10 to 15 years, and their prime is about 5 years. So there is no way you can actually make any mistakes in sportsmen, right? So the use of ultrasound, yes, definitely helps you. But at the end of the day, so Akhil was talking about and the specificity of ultrasound in picking up rotator cuff injury, so that's fine. But again, you will be able to pick up the rotator cuffs, but you will miss your slap pairs and stuff. So there are limitations for the technology as well. And second is, unlike in the West, in India, we may find some medical-legal implications for this as well. So I treat a reasonable amount of sportsmen, including the Chennai boys, the CSK boys, and the BCCI boys. So to tell you the truth, ultrasound is fine. We use it for imaging, but we have very little threshold for ordering MRIs in sportsmen. And you'll be surprised. I know all the physios. I know the physio of the Indian cricket team. He has a big pouch, like the pouch that he wears on his face, and he has a pen drive for each of these players, and each player there is an MRI for the right shoulder, left hip, right knee, and all that stuff. So in sports medicine, yes, can be used for big growth, but rather be safe because these are elite sportsmen. So don't hesitate to order the MRI. So that would be my take-home point. But yes, ultrasound is very useful. Thank you.
Okay.
Any other doubts from the? Yeah, sorry.
Yeah. I completely agree with you, sir. Because ultrasound definitely has a big role in detecting in some of the structures like rotator cuffs, as he said, very fine tears and all those things can be very well diagnosed. But many a times in excitement we don't order MRIs in practice also sometimes, and that's where we miss the small ligament injuries and the slap tears, as you said. And then after doing the procedure, we feel that yes, the patient is not getting that kind of a relief that we expected. So that thing we have to be very careful about. And one thing actually, since the article that Shreya presented was data in this. If we take different sports like cricket or badminton, we can have a data of all the athletes on a large scale, and actually we according to that we can have a specific you can say protocols developed for that specific sports, and then we can train those athletes according to those. And this is one more aspect that can be used in the future, I think, with this technology. That is all from me.
Right. Thank you. Any other doubts, put it in the chat box. I'll just make one more comment here. See, since most of you are young and you're all becoming more and more better in using ultrasound, just like a message from me. Come up with a technique where you can store your images, right? So a lot of times what happens is the MRI is there forever, the report is there forever, we can pull it out, the report can be pulled out. Now that as we are doing more and more ultrasound, and 2 years down the line, somebody can put a medical legal case on you saying what was the finding. So this is more a suggestion, I'm throwing it out to all of you youngsters. Come up with techniques where you can store the images of ultrasound so you are safe in the future, and also you can sort of know the progress of these injuries, because for the initial diagnosis, I would say use the ultrasound plus get the MRI also. But a lot of times, if let's say you do the treatment, which could be a PRP shot or a BMAC shot or a steroid shot, these patients become functionally better and we don't follow up essentially with an MRI. So maybe follow up with at least OP visits, and ultrasound is a good idea. So for that, you need the previous image. So come up in your own practice, come up with your own ways of storing ultrasound images. That will make a lot of sense. And it will also give you data to publish these things in the future.
Great suggestion, sir. We have one question. Meanwhile, I'll just like to pull it up. Dr. Bhanushri says, treatment options for mucoid degeneration in ligaments. Over to you, guys.
The question is for me.
So for all of us,
Yes.
Just open. Anybody can just take over. So treatment option for mucoid degeneration in ligament. Actually, you are doing most of the sports work, so I think you are the most apt person to start.
Okay, madam. See, mucoid degeneration, first of all, you need to assess if you're going to really treat these patients, okay? So not all mucoid degenerations you need to treat. So if you're looking at, let's say, one of these joints and one of these ligaments is showing, and these patients are functionally better, a lot of times we just leave them alone, right? So never forget the PRICE protocol. For those of you who don't know, the protect, rest, icing, compression, elevation, along with appropriate short dose of anti-inflammatory medication. If this is sufficient, then it's sufficient. No need to actually treat it, right? So a lot of times we find that this sort of trivial injuries with conservative treatment, they come around. So never forget the PRICE protocol, okay? One. Second is, in terms of options, you are left with three, probably, okay? So one is, if it is really symptomatic and it's not responded to like the PRICE protocol, what you can do is, first, option one, a cortisone shot. Second, you have an option of doing a percutaneous tenotomy. I'm not saying you're going to do this in this case. Third, you can do a PRP, correct? So these are the things that you're going to do. So most commonly, this sort of thing you'll be able to see in the commonest ligament that you're going to see a mucoid degeneration is an ACL, right? So that being the case, percutaneous tenotomy is ruled out because it's a ligament here. PRP is a good idea. BMAC is a good idea, right? So try conservative treatment. I'm not a big fan of steroid injections. So one option would be conservative treatment. The other option could be an intraligamentous PRP. But again, try to manage conservative.
Great, Dr. Okay, yeah, go on, Dr. Sanjog.
Okay, Karthik sir, do you inject for these ACL ligaments? You inject inside the ligament or just in the joint space? And if in
decide whether it's more the distal aspect of the ACL that's involved or the entire ACL that's involved. So the distal aspect of the ACL can be seen to a certain extent with ultrasound. You can't see the femoral proximal part of it, right?
Yes. Yes.
So usually, most commonly, you'll see both part of the ACL is involved. So what I do is, since the proximal part is involved and I can't see it really with ultrasound, I do this procedure with fluoro. So what I do is I put, after giving local anesthesia, sterile precautions, 2 spinal needles into the structure which I think is the ACL. I give contrast. So contrast with PRP is okay. So I try to get the proximal part of the ACL, give contrast and make sure I'm inside the ACL and distal, and then PRP. Intraligamentous ACL injection of PRP.
And have you done any PRP for the meniscal tears also? Because some articles are coming which are giving.
Off late. See, essentially, cartilage is a different type of protein. So whether it will grow or not is subjective. So if you see the meniscal tears, so you have longitudinal tears and then you have bucket handle tears. So bucket handle tears, like the name suggests, it's the bucket handle, right? So each time the patient is bending the knee and straightening, it is going to keep scratching. Okay, yes. So this knee is going to regenerate over a period of time. Second is these patients are prone for early osteoarthritis because this is always scratching. So patients, if you leave them untreated, they will eventually come up with an early osteoarthritis, like 48, 50 years, they'll come back. Okay. So off late, bucket handle tears, you have to go and operate. You can't do knee PRP for bucket handle tears. Linear tears, sometimes you can get away. Meniscus off late, there are some evidence that PRP can be tried for meniscus, but probably not conclusive enough. So you have to see the overall functional status of the player and then take a call.
Thanks.
Great.
Sir, I have a question.
Yeah, Dr. Akhil and Dr. Sneha, if you have any questions, please put it up now.
Sir, I have a question. For knee osteoarthritis, and I'm not discussing the grade of osteoarthritis, but if the patient with knee osteoarthritis presents to you, and the patient may or may not be affording, but how do we choose? Not exactly we, but how do we choose not to do a steroid injection or go for a PRP? What is the criteria, or we don't give steroid so much so often nowadays, and when do we go away from PRP and give steroid only?
Okay, so probably when I would consider steroid, actually I've stopped steroid now, but when I would consider steroid, so you take it as Kelly-Green-Lawrence classification, grade 1, 2, 3, 4. Okay, grade 1 you manage conservatively. High grade 3 and grade 4 you refer for surgery. So you are left with grade 2 and low grade 3. Okay. So grade 2 and low grade 3, in terms of interventional pain management, you have 4 options. One is a steroid, one is HA, one is a regenerative product, fourth is denervation, genic learner. We are left with steroid, HA, PRP or BMAC, and denervation. So per se, you may be doing interventional procedures in high grade 3 and grade 4 if the patient is unwilling or unfit for surgery, correct? So in unwilling or unfit group, your duration of the interventional procedures will be less than in the grade 2 group. So that's what you're left with. So you have an option of choosing steroid, HA, PRP, or denervation. Sometimes you can use a combination of all of this. So steroid is actually, if at all there is an indication, it is for people who come in early. Like once in a while, you'll find patients who are coming in at 51, 52 years of age. And if affordability is a big problem, that's probably when I would consider. You'll be surprised that in the 51, 52s, when you do a steroid injection, this will work for longer, provided they are not very heavy, they're not very obese, right? So it may work for 4 or 5 years. But post 55, so the heavier ones almost completely stop using steroids. It's either PRP plus HA or series of PRPs, or off late we also started doing bone marrows. And you'll be surprised that if you keep doing reasonably large numbers, the cost will not be such a big factor at all. So you'll save on a lot of things. So it'll be totally worth it if you can do a PRP for these patients. Again, don't waste your time doing PRPs in grade 4. So a lot of times people get overexcited. They try to do PRPs in bone-on-bone conditions, grade 4. And not only will you get disappointed, patients get disappointed, but sometimes you'll spoil the name of the procedure that you're doing and the specialty. Right? So don't waste your time in grade 4s. But in grade 2, grade 3, very rarely I do steroids, but that's the indicator.
Sir, another question. And sir, how do we choose between hyaluronic acid and PRP? If it could either be linked or cross-linked or non-cross-linked, but how do we choose between PRP and hyaluronic, especially when so in some cases of severe arthritis, we would want to avoid PRP maybe initially?
So, per se, the hyaluronic acid, off late, there are studies which show that there is some sort of synergism between HA and PRP. Correct? Now, off late, you are getting some studies. So, the hyaluronic acid does two things. One is it's a sort of substrate on which your growth factors can sort of grow. That is one. Second is, per se, if you just put PRP, the effect kicks in like after 3-4 weeks, realistically. So the HA gives you a little bit of cushion initially. As soon as you do the injection, they sort of feel a little bit better. So that's the main role. Per se, some studies are showing there is a bit of synergism. The HA is some sort of substrate on which your growth factors can act. We have also tried HA with BMAC, and we found personally, probably my numbers are not that much, but we found the results are better. So roughly, if somebody asks me how in a grade 2 osteoarthritis, how long a PRP plus HA would work, I'll say somewhere around 6 months. How long a HA with BMAC will work, I'll say 1.5 to 2 years. So personally, my results, BMAC, they have worked a little bit longer. And and also it gives you initially for the regenerative product to kick in, it may take about 2 to 3 weeks or maybe more than that, especially in the bad ones. So initially the HA gives you a little bit of.
Sir, one last question. And when would we think of going for a stem cell injection if the cost is not an issue?
You can think anytime. So when you say stem cell, PRP or any product from the blood normally does not contain stem cell. Right? So PRP has only growth factors. If you give some other medicine, you can bring stem cells to the blood, but normally blood does not contain stem cell. Right? So when you talk about stem cell, we are talking about 2-3 products here. Different variations are there, of course. So we are talking about bone marrow aspirate concentrate, which is BMAC, which is usually taken to the iliac test. Then you're talking about adipose tissue. So adipose is done like a liposuction around the tummy. So these are your 2 commonly available products. There are different variants of these things. So if for all practical purposes, in a normal grade 2 osteoarthritis or grade 3 arthritis, you can straight away go for BMAC. There's no specific indication. Okay, one. So when you see, normally when musculoskeletal sports or musculoskeletal injuries, when PRP first came about, we had 4 indications. One is a tendonitis, second is a partial thickness tendon tear, one is a partial ligament tear, fourth is osteoarthritis. So in the rest of the 3, that is tendonitis, almost never, we don't require PRP at all. Partial thickness ligament and partial thickness tendon tear, when the tear was extensive, we would use BMAC. In osteoarthritis, it doesn't matter. From my way of looking at it is, for osteoarthritis, when I use BMAC or adipose tissue, the effect is a little bit longer. There's no particular indication per se. You can interchange and use. If you can use it, the effect is long. And of course, the patient should understand what you're trying to do. And off late, they have sort of become legal in India. So we are actually medico-legally safe as well. So they fall into this category called minimal manipulation. So when you say minimal manipulation, that is allowed. So the product should never leave the OT. A little bit of centrifuge, all that is fine. but you can't add any chemical additives and all that stuff. So at this point of time, as much as I know, BMAC and PRP are quite legal in India. Adipose tissue, depending on the type of technique you are using, that is also legal.
There's one question in the chat, sir. Can we grade knee osteoarthritis based on cartilage thickness in USG?
No. The thing is, the same cartilage, if you look at it in one axis, may look like 1 millimeter. If you look at it in another axis, it look like 3 millimeters. So, based on cartilage thickness to grade is very tricky. One. Second is, sometimes people do claim that after 3 PRP injections, the cartilage thickness has actually increased. Probably not. Very difficult to document that the cartilage thickness is actually increased after PRP. These patients may be functionally better. Your aim may be achieved, but cartilage thickness worldwide, nobody has studied, and nobody has actually told that cartilage thickness can be reliably used for osteoarthritis. MRI may be used for showing cartilage growth, but very subjective. Cartilage thickness is very subjective. The same cartilage, I can show it and say it's 1 millimeter. Sneha can come and look at it at a different angle and say that's 3 millimeters. So very subjective. So it can't be used very reliably as far as I know.
But there are articles which say that, sir, in USG, by keeping the knee totally flexed, the posterior aspect of the condyles come and we can actually detect the early
I used to do, we were 3 fellows and each one used to do and we got a different value. So like it was like always that time the knowledge was not too much. I mean, right now we know, and then we're all struggling and as what is this, and then it was very difficult actually, and it's not possible. So even the same observer, if you just lift the probe and then keep it again, you may find a different value. Also, this is probably a non-compressible structure, but many structures are compressible also. So a lot of things will change with this. So and maybe something like that. Just a word before we just kind of end the session.
See, treating the sportsman, you have to take it as a responsibility, right?
Yes.
So you have to think of a sportsman like a film actress. The film actress has only a short shelf life, so they have only a short shelf life. Okay, so and any mistake, even if he becomes fit after 1 year, after like right now there is a controversy regarding Shami. Shami's MRI actually came up. He had an ankle thingy, and the NCA in the Bangalore, which actually they said you try conservative treatment for 1.5 months. So in 1.5 months, he missed the Australian series now, the England series now, and now they told you go to UK and undergo a surgery. So basically, if the sports doctor had said go for the surgery then, he would have come back faster. Right? It's not a blunder. They tried conservative treatment. It's not a blunder. But now people are saying, why did you make him wait for 1.5 months? You could have sent him for surgery to UK earlier. So he'll come back earlier. So right now he'll miss the IPL and he'll be coming only for the Australia series, hopefully. So any mistake, they will look at it with a microscope, right? So there's no role of taking any chances. In fact, for sportsmen, even if I'm 100% sure about the diagnosis, before treating, we will get opinions from 2 or 3 others in the team. So all of us should concur. Only then we'll offer treatment.
Great. So teamwork will actually have a double effect. It will cushion you against any counter suit later on, and also it will give the best possible opinion to that patient or that sports person. Great. So if we have some couple of questions, quick answers to them. What is the amount of concentration of hyaluronic acid you use along with the PRP? So I think the standard.
Standard doesn't make a big difference. In
Right.
fact, if you really want, you don't require. Sometimes you get which are 4 ml, 5 ml, 6 ml. So sometimes you have a 6 ml hyaluronic acid. You can use 3 ml for both knees. So when you're doing for knee, don't go overboard with your volume, right? So if you are using, let's say, 3 ml of hyaluronic acid, that's enough. Try not to use local anesthetic, so that's going to complicate things. So 3 ml of local anesthetic plus, let's say, 4 or 5 ml of good quality PRP is good.
Great. The last question is no pain relief after PRP injection in grade 2 osteoarthritis knee. What's the next option? Very, very nice question.
What can I say? Repeat it.
Stem cells.
Repeat it with
BMAC. Repeat with BMAC, then repeat with allogenic stem cells. So actually,
very difficult for us to answer that.
Yeah, it's very tough to answer. There is no protocol for this, so that's why we all are in this thing. Because while we actually struggle to convince patients in grade 2 OA knee to get the injection done, it is very difficult. Maybe grade 3 people will agree, grade 4. So then, of course, you have a very good question that what to do next. But what probably we'll do is don't repeat your procedure to very, very soon. Just give a good waiting.
Yes. So a lot of times, see, the growth factors has to come from the blood. And a lot of times people try to use a very small volume of blood and say they can concentrate, they can enhance it, they can activate it. Probably not true. If you see worldwide, the best company for PRP throughout the world, or all of these studies, the best company is the US company called Harvest. Right?
Yes.
So Harvest has a system which I personally used for knee injection. Can anybody guess how much volume of blood that needs to be put in the Harvest system for one knee to make PRP? Can anybody guess how much volume of blood needs to be put in the Harvest system for 1 knee? Yes, 60 ml of blood to make 6 ml of good quality PRP in the Harvest system.
Yes.
And a lot of times in the conference, I find people are saying they'll take 4 ml blood and activate it and make it into fantastic PRP, 6 ml blood and make it into fantastic PRP. So only if you have initially good platelets, you can actually make good quality PRP. So you'll get into trouble when you use not the best product. So also concentrate on the product. I'm not recommending a commercial kit or anything like that, but make sure whichever kit you are using initially uses more blood so you get better quality PRP. Okay. Thanks.
Great. So thank you all. Thank you for the excellent discussion. And I think it has been time now, so we'll just wind up. Thank you both the speakers for the excellent presentations. Thank you, Dr. Sanjog, and thank you, Dr. Karthik, for sparing your valuable time. You have become now the star sports treater. So I think even more valuable your time has become now. So thank you so much, and we had a great discussion. So we end this session now, and we go on to the last slides. So this was the season 4 of the Mumbai Pain Schools Pain Journal Club, and this season we focused on the Mumbai this MSK Ultrasound, and we had a new time 8 p.m. and group topics and 2 faculties and 2 papers, and of course uh, sometimes we could just put in the paper on the same day, but we tried to cover up all these topics in the best way possible. And the next steps, now we are, those of you are here for the first time, please join our mailing lists. Just check the link in the WhatsApp, in the chat for the WhatsApp group, and join us. Any suggestions, comments are welcome. Just mail them on mumbaiPainSchool@gmail.com. And do join us for our upcoming hands-on WebSeries workshop, 26 to 28 April. So this was the end of the season 4, and we'll have a new season very soon. Until then, I think it's bye-bye from us. Thank you.
Thank you, Sidharth. Thank you, everyone.